right. I think we're going to get started in honor of trying to keep on schedule. All right, so we're going to get going. Once again, thank everyone for coming. It's always wonderful. Zach is kind to provide us always with a very erudite lecture, pretty much every year now, I think, as I've looked through your CV. So I've announced and introduced Zach many times, and he's someone who really doesn't need much of an introduction. But as I looked through his CV this time, I found a few of the unique facts that I'll share with all of you. Nothing bad. So for those of you who didn't know, Zach graduated from Princeton as a mathematics major with honors, and then decided to go into medicine. So I found that very interesting. You usually see some type of a bio or chemistry or some other type of major. So that was very interesting. He did his fellowship training at Vanderbilt and very rapidly moved up the ranks and has been a full professor here at Sani for well over 10, I think almost 15 years at this point. He has over 500, well over 500 publications on his CV. And for those of us who aren't that productive in that area, that is really quite impressive. And always has some really helpful insights, both for mentoring, I know for me and many other of the faculty within the division, as well as our fellows. So we look forward today to another talk by Zach, this time speaking on insulin resistance, diabetes, and cardiovascular disease. Thank you.
Thank you, Kara. So I'm going to try to talk at a normal loudness, but if I get, start going down to my usual mumble, just yell at me, throw things at me, and I will try to speak louder. Elliot, please let me know. So on a sober and sad note, I do want to recognize that Andy Draxler, who was truly my best friend and was the head of the Mount Sinai Diabetes Institute until 2002, and then moved to UCLA, where he was the head of the Institute for Diabetes until 2016, developed an obscure form of liposarcoma, got better, and then had rapid progression over the past 6 months and passed away about a week and a half ago. So he will truly be missed. And he was going to come back to New York and spend more time at Mount Sinai, and I certainly wish that had been the case. So this is going to be my talk for the World Congress on Insulin Resistance in about a week and a half. And I was honored by getting the Reason Award for contributions. And I said, well, what do I do? I have a lot of patients with diabetes, and I write commentaries, and I do a little research, but that award seems silly. So then I looked around and I said, well, what constitutes an expert? So here's a cartoon by somebody who writes cartoons for the New York Times, and here's all you need for expertise. Focus, find patterns, go in some depth on some of them, get the intersection, and then you have expertise. So this was a lovely quote in one of the early articles I found. The secret of all learning lies in the passion for the search. And so the wonderful thing about medicine is that we're able to really go over so much and understand so much. So here's my favorite website in the entire universe, PubMed, which linked to the Mount Sinai Library allows you essentially everything. So it's sort of a time machine in a sense, because if you type into the search bar, quote, insulin resistance, end quote, and then brackets title, so it'll only look for articles limited to insulin resistance in the title, then you come up with these, interesting numbers of articles. So 2 articles in the 1940s, 11 articles in the 50s, or through 60s, 29 articles through the 80s, tiny numbers, but then zoom. So here's the growth of articles on insulin resistance, and it's quite remarkable. So I thought I would take a look, and my assignment from Yuta Handelsman, who has spearheaded the World Congress on Insulin Resistance for all these years, and he said, pick an interesting title, and what are you going to talk about? I said, well, my research, I don't know, my articles that covered so many topics. So I said, well, insulin resistance, looking back and looking forward. So let's look back. So here's one of the earlier articles on insulin resistance, and mentioning that insulin can be characterized as the hormone lowering blood sugar. And we can kind of use that for a operational definition of insulin resistance. So this was 1940. And here's an article from 1947 in the JCI looking at characteristics of insulin-resistant persons. But this was not exactly what we think of when we're talking about insulin resistance today. There are articles, here's one from 1950 or so on lipodystrophy, essentially the impure insulin preparations causing local areas of lipohypertrophy. And if you continue to inject in those areas, as people still do today, you'll get resistance to insulin's action. There is even, I don't know how many of you knew Henry Dolger, but this is going back to our history at Mount Sinai. He was the head of the Mount Sinai Diabetes Clinic many years ago. And when I first came to Sinai, this was part of the fascinating and wonderful ambiance. And once a month, we would get together and have a diabetes conference. But it was at someone's apartment over cold cuts and various things that I was the kid. So Henry Dolger was a lovely person whose ideas of diabetes management differed quite a bit from those of today, but who as a physician really was so wonderful to his patients. Here's the Lilly lecture of 1957. It was actually given then at the American College of Physicians meeting. And this was on insulin resistance. And this looked in more detail at what is really not at all our insulin resistance, but it's related to having high levels of insulin binding antibodies in the blood. And so that's where the disease was at that time. And there's a patient who was taking 50 units of NPH once a day or whatever it was, and then went up to 500 units a day, and then somehow the insulin resistance resolved, steroids and all sorts of things. And of course that is insulin resistance. But this is all without knowing even what the insulin is. And then another famous part of Mount Sinai's history, really, is Gallo and Burson. So Saul Burson was the chairman of the Department of Medicine. Gallo was at the VA. They did all their research at the Bronx VA. And they, this article apparently was rejected 5 or 8 times by the JCI. And Gallo would show slides of the rejection letters, which he kept to say to them,
Kind of resistance.
kind of resistance. So this was the very first immunoassay, and here's data. So here are patients, these are insulin levels. Here's people without diabetes, huge variability of insulin. Here's people with early diabetes, poorly characterized diabetes. So this is a fantastic tool, and we take it for granted now that we can measure insulin, we can do all of these things. My mentor as a fellow was David Rabinowitz, who moved to Israel, changed his name to David Rabin, was a fantastic endocrinologist, wonderful teacher, wonderful person. And this was one of his early articles where they took people and they had assays from Burson and Yinghua of normal levels of insulin at 9, people who were obese with an insulin of 30, and they found that here's a link in the chain of evidence of obesity being linked to maturity onset diabetes, which we've now decided to call type 2 diabetes. So here's skipping ahead a few years, 1970. Here's another JCI article by Jerry Reven, and they took a group of people with diabetes, a group of normal people, height, weight, and so on. So they tried to match them for age and degree of obesity, and obviously the normal ones had much more normal glucose tolerance. The ones with diabetes had mild diabetes. And what they did was they infused insulin, measured the insulin levels so they were able to get a steady state plasma insulin of about 100 microunits per ml. And then they looked at how much glucose you needed to infuse to maintain euglycemia. So this was the beginning of what we've been called the SSPG, steady state plasma glucose, which is a perfectly nice way of looking at insulin resistance. And they found that in the diabetic patients, actually here it was done slightly differently. So they infused the same amount of glucose, they had similar insulins, and they found that the blood glucose levels were lowered with diabetics. Right, and so the steady state plasma glucose done here is with a given level of hyperinsulinemia, what's your blood sugar, and of course it's higher in people with diabetes. So then, using the same approach, they said, let's look at the SSPG in individuals with obesity who lose weight. And lo and behold, this doesn't seem to actually show up on a white background.
But you can see it.
Okay, you can see very nicely that the SSPG goes down. So then, here's an article in Diabetes in 1985 looking at glucose uptake, total glucose uptake, and insulin-stimulated glucose uptake. And they showed a marked difference in insulin-stimulated glucose disposal in individuals with diabetes versus normal individuals. So this is insulin resistance as we think of it today. So in 1988, Reven gave the Banting lecture at ADA on what he called then Syndrome X, in which we now call the insulin resistance syndrome, the metabolic syndrome, a lot of other terms for it. And he said, here's a condition of resistance to insulin-stimulated glucose uptake, high insulin, increased VLDL triglyceride, decreased HDL, high blood pressure, and on and on and on. And so this is one of those things that I was actually at that ADA thing, and everyone said, well, sure, I do that, but nobody actually said it. And this is the important insulin resistance that And then here's an article by Tracy McLaughlin, who is still at Stanford doing these studies of insulin resistance in Regan's group. And they took large numbers of individuals and they looked at various parameters to see, using this, looking at sensitivity versus specificity to do an area under the curve and say, what's a good marker of insulin resistance? And so it turns out that triglyceride or the triglyceride to HDL ratio are basically as good as the plasma insulin in determining whether somebody has insulin resistance. And that's with this particular SSPG approach to characterizing insulin resistance, and it might not be so in general, but really the triglyceride level is the readily available marker of insulin resistance. And in this population, the BMI was considerably less useful than the insulin level or triglyceride level in characterizing people with insulin resistance. And Regan, who really was the guiding spirit of the World Congress on Insulin Resistance for all these years, would constantly say, forget about HOMA. HOMA is just blood sugar times insulin level. Just look at the insulin level. That's really all you need. And the problem, of course, is that insulin assays are not very well characterized. And so insulin of 20 in one lab and 20 in another lab don't necessarily mean the same thing. So triglyceride is probably a better general way if you have to look at it sensibly and say, well, people who have genetic forms of hypertriglyceridemia don't really have the same thing. But by and large, people with triglyceride levels of 150 are insulin resistant. So this is a very lovely approach. So what tracks with insulin resistance? Here's Stefano Del Prato. He had an article from a long time ago. He looked at people with insulinomas. And so here's a hyperinsulinemic euglycemic clamp, people with insulinomas, looking at the glucose disappearance rate in normal controls and in people with tumor-related hyperinsulinemia. And you can see that using tracers, the rate of glucose disappearance is far lower in people with hyperinsulinemia. Or simply, in this panel on the right, if you look at the amount of glucose required to be infused to maintain euglycemia, it's much greater than normal. So hyperinsulinemia itself begets insulin resistance, and this is our form of insulin resistance. What underlies insulin resistance? Well, obesity is the major factor. So looking at this time machine of PubMed, here's a wonderful article from Framingham looking at prevalence of obesity in the 50s, 60s, 70s, 80s, 90s, 2000s, and look how it went up from 10%, 13, 20, 25, 32, and of course this is continuing to go on. That was in men, women, the same, basic pattern. And here's NHANES, which is a wonderful epidemiologic data set that's now in its, I think, 8th iteration, giving population data on all sorts of characteristics of people in the United States. And so look at the prevalence of BMI greater than 30, going straight up from the 1970s to the 2000s, and BMI greater than 40, much lower, but the same kind of trend, and a modest decline in overweight. So this is kind of another study of historical interest. So here's Itamar Raz, Jesse Roth, looking at, this was published first in Diabetes Care, then in a slightly differently analyzed article in Diabetes and Metabolism Research Reviews. If you look at individuals in the fifth quartile of fasting insulin at age 49, the fourth quartile, third quartile, second, first. So as the insulin level, the baseline insulin level goes up, the likelihood of dysglycemia versus euglycemia changes exactly as one would predict over a 20-year period. So this really is the underlying condition of diabetes, and the predictors are obesity, fasting glucose is related, ethnic factors. It's an Israeli population, so the ethnicity a little different from the U.S., but the same ideas. Hypertension, Ferranini have done wonderful studies with DeFranco showing that essential hypertension and type 2 diabetes are approximately equal in prevalence of insulin resistance, triglyceride levels, more in males. So now let's look forward. In order to look forward, I said, well, let me just look at the most recent 1,000 articles on insulin resistance. And I didn't actually go through all 1,000 articles, but I went for about 200. And there's all kinds of interest. So this is just a smattering of an idea on what's going on in insulin resistance today. Of course, the first 1,000 articles occurred over a 35-year period or more, and the last 1,000 articles in this search were done in 2019. So this is a hugely growing field. The linkage with coronary disease. So this is I think a Korean population of individuals who did not have known coronary disease and were referred for CT angiography of the heart. And so it's a mishmash, and who knows what the characteristics of these people really are. But very interestingly, if you look at HOMA-IR, or if you look at triglyceride glucose index quartile, another similar measure, but triglyceride alone would probably do the trick, or triglyceride to HDL ratio. If you look at people who don't have diabetes, as you go from the lowest to the highest quartiles of insulin resistance with all these measures, you see that the prevalence of coronary artery disease goes up by about a third. The triglyceride measures same sort of data. If you look at people who have diabetes, the increase is quite similar, except instead of going from 32% to 45%, it goes up from 58% to 70%, showing what we know is the important effect of diabetes in and of itself in increasing the likelihood of coronary disease. And here's another interesting article looking at essentially the same topic. So here's an article in JAMA that came out recently, so the question is, what about bariatric surgery? Here's really the only effective way we have of reducing obesity. And should we do it more? Should we not do it? But what exactly is the story? Well, if you look at a population of more than 2,000 individuals who've had bariatric surgery and then have a roughly comparable control group, you can show that the likelihood of developing cardiovascular endpoints went down by about half in those people who had bariatric surgery. So this is essentially insulin resistance. So here's a lovely article, which again was published this year, So they took a look at more than 10,000 individuals in hands, actually more than 20,000, who had normal glucose tolerance, impaired glucose tolerance, or diabetes. And they said, what are the associations of HOMA-IR? So HOMA-IR is the blood glucose times the serum insulin divided by 22. And actually, there's another version of HOMA-IR calculation, which is an update. This was done by the UK PDS group many years ago. And so they could similarly have just looked at the relationship of serum insulin to these endpoints. And they have three different adjustments. The third adjustment includes body mass index as one of the factors. So we'll see what that does. So first, very interestingly, a relatively robust, apparently, measure of general health. And as you go from the greatest degree of insulin sensitivity to the least degree of insulin sensitivity quartile, you see a reduction in general health. You see all the things that we think of as these lipid measures. So triglyceride levels go up, and not much of a fall off if you do the full model where you adjust for BMI. And HDL goes down. Maybe that's a little bit more attenuated by adjusting for BMI. Triglyceride HDL ratio, same thing. If you look at LDL cholesterol, it definitely goes up if you don't take out BMI, but that's really the association of LDL with BMI. If you throw in BMI, there's no relationship. So LDL is not particularly related to insulin resistance. Liver chemistries, so GGT, ALT, not so much AST. None of this is striking, but it's fascinating that here's this very large analysis that was published in, I forget what journal, but relatively obscure journal that I would have never seen, but a beautiful analysis. Here's all the parameters of the CBC tracked with insulin resistance. The white count, everyone knows that obesity gives you leukocytosis, and it gives you lymphocytosis, and elevated neutrophils, and elevated platelets, and elevated hemoglobin. And these are pretty robust associations. And vitamin D, okay, so we know that vitamin D goes down with insulin resistance. Probably much of that is related to obesity, but who knew, at least not me, that folic acid, B6, and vitamin C also track with insulin resistance. So one can either say, well, what does it mean, or maybe vitamin C is coming back. I had a lovely conversation with someone who actually had started off as a biochemist, got an award during his postgraduate period for Linus Pauling, which he proudly told me about, and now is off to get a vitamin C cleansing somewhere in California. More seriously, here's retinopathy, markers of retinopathy in a cohort without diabetes. So if you look at that, there's actually essentially no significant association with hemoglobin A1C, but there's a highly significant association with HOMA-IR. So this is one of these lovely things that one can find epidemiologically. Lovely and frightening and important for us to know about. So then I said, well, I should really try to look through these articles and see if I can understand the science of insulin resistance. So I knew that Chris would be here, and I said, this is going to be really tough. If I can get through the next half hour, that I'll feel okay. So here's a very ultra simplified view of the insulin action pathway. So these are all images from Wikipedia. And then I looked at a couple of very nice articles by Jerry Schulman in New England Journal this year, another interesting article in Frontiers in Endocrinology, which I agree with the associate editors of Frontiers in Endocrinology. And I regret it because I get about 14 requests to edit an article per week. And they require huge levels of editing, really going through it and not just assigning it to reviewers. So I'm not very good, but I do read their articles, and this was a nice one. So here's insulin on the top, binding to the insulin receptor, which then autophosphorylates after insulin attaches to its receptor. This leads to PI3 kinase. And I think of these as letters, sort of. But the reality of these very complicated molecules is obviously far, far more difficult to understand than my very simplified black box version. And then this, in turn, activates AKT, protein kinase B. And then this goes on to set up a series of effectors. Elevated insulin itself can cause insulin resistance, as we saw from that insulinoma study. And then a group of circulating factors are associated with insulin resistance. Products of fatty acid metabolism, diacylglycerol, ceramides, the certain amino acids, and we're going to try to go into some detail on the interesting relationship of branched-chain amino acids to insulin resistance. What is some of the new information on insulin resistance? Here's a study that looked at macrophage function in a rodent model with insulin resistance. So first of all, here's AKT phosphorylation in control animals with insulin going nicely, attenuated in the insulin resistant model. So this was a high-fat diet feeding protocol, very well worked out. And then if you look at a marker of resistance to infection, so here was a peritonitis response where a lesion was made in the gut. Bacteria were allowed to go into the peritoneal cavity, and in the insulin-resistant animals, mortality occurred much more quickly, although it looks like being an animal enrolled in that study, regardless of whether you were on a high-fat diet or not, wasn't so good for you. So they all succumbed, but more rapidly with insulin resistance.
Actually, sorry, can you just go back? Doesn't it show that the high-fat diet is protective, which kind of blues high-fat diet, right? So they have increased survival, right? Which is actually blue.
So,
right. So that is actually consistent with the cachexia talk we heard like two months ago, where surprisingly obesity is actually protective in survival when you are.
So I got it. This is why I wanted to give the talk now, so that I could, when I give it in Los Angeles, I could know what I'm talking about. Okay. So the bacterial load was greater with the high-fat diet. So it's not that it's protective against the phagocytic function of the macrophages. So we'll just take off the survival part. Not so important. They all succumb. So now, keep looking carefully. I need this help. So, fascinatingly, if you look at the same sort of model of insulin resistance, so here's a high-fat diet, you can demonstrate both in the skeletal muscle and in skin that there's decreased phosphorylation of AKT with insulin. And so there's skin insulin resistance there. So what did they find? And I didn't put all the data slides here, fortunately, since Chris would have taken them apart. But barrier function, so transepithelial water loss, keratin levels, skin keratin, subcutaneous adipose tissue, and increased infiltration by macrophages in the subcutaneous space. So insulin resistance expresses itself in skin, and this presumably is related to the association of insulin resistance with a variety of dermatologic problems, for example, psoriasis, maybe the relationship to acanthosis, and so on. There's very interesting associations of insulin resistance with gut flora. And here's a study of oral flora, and I won't even attempt to give an explanation of what these bacteria are and what it means, but there clearly are different populations. Here, looking at glucose change over time is sort of a poor measure of insulin resistance versus bacterial flora and differences in population levels. So there's a lot to this whole phenomenon of the microbiota, and it's certainly can be seen in the oral flora. Here was an insulin resistance model, which then looked at insulin resistance in the heart. Here are here's cardiac glucose uptake basally and with stimulated by insulin. In this abdominal aortic coarctation model, they were able to demonstrate that cardiac glucose uptake was reduced. So here from 74 and then stimulated 60.61. The numbers are irrelevant, but decreased stimulated glucose uptake with aortic coarctation as presumably a model of hypertrophic cardiomyopathy. So they were able to show that there was an association with abnormal mitochondrial function and the cardiac matrix loss of vacuoles and so on. Now, is this a direct causal effect of insulin, lack of insulin action, or are there other mediators? Not clear, but certainly it's an interesting suggestion. And then that was a rodent model of some sort. So then, one of the really striking associations of insulin resistance is this whole idea that Alzheimer's disease is type 3 diabetes. And so here's another of these population studies. This was done in Finland with a relatively small group of about 30 individuals who were either characterized as having normal insulin sensitivity by HOMA at age 55 or reduced insulin sensitivity. And then they looked at age 70 at psychological testing, and they found that there was a reduction in executive function and in processing of speech in individuals who were insulin resistant 15 years earlier. So this is very complicated. There are a lot of potential factors. It may be that there are socioeconomic differences between insulin resistant and insulin sensitive individuals, and that this is not measuring insulin action at all. But there is this very interesting metabolic hypothesis of late onset Alzheimer's disease, where central, i.e. central nervous system insulin resistance is associated with inflammation in the brain, mitochondrial dysfunction, so oxidative stress, decreased energy availability, the production of increased levels of plaque, and then maybe these abnormalities in the insulin signaling pathway cause the pathological and functional changes of Alzheimer's disease, or at least contribute. And one of the fascinating associations, there's an interesting, complicated article on this topic, and it looks as though the hippocampus is the major site of setting down memories, and that insulin action plays a role in memory, and insulin resistance decreases that. And there are a number of fascinating studies. You can get insulin into the brain very easily by administering it intranasally. And so it may be, and when you do that, it goes in a totally non-physiologic fashion into the rhinal cortex, and maybe this memory improving effect of large doses of intranasal insulin is related in some fashion to insulin action at the hippocampus. So let's move a step away and go to one of the older markers of insulin action. So here's PPAR gamma, and there's PGC1 alpha. PPAR gamma co-activator, 1 alpha, has decreased expression in people either with diabetes or with a family history of diabetes. And if you look, for example, of one of the genes related to oxidative metabolism, so here's pyruvate dehydrogenase, it really appears to decrease in individuals with insulin resistance. Okay, what's the importance here? Well, here's a study in JCNM almost 10 years ago, which looked in an animal model at DNA. This was this is in man, looking at skeletal muscle PGC1A expression on individuals with low birth weight versus normal birth weight. It appears that individuals with low birth weight develop peripheral insulin resistance in response to a high-fat diet. And skeletal muscle biopsy shows a DNA methylation of PGC1 alpha. So maybe part of this is actually an epigenetic effect that's linked in some way with developmental exposure to insulin resistance causing stress. So why am I bringing this up in the context of Alzheimer's disease and cognitive impairment? Well, here's an article that just came out October 2019, maternal insulin resistance and then synaptic plasticity and memory in subsequent generations. So without trying to go through the actual data, here's their cartoon. It appears that long-term potentiation of memory is abnormal through the third generation after exposure to insulin resistance causing environment of the maternal side. So how exactly is this carried out? Not clear, but this is an interesting way of perhaps linking the neurocognitive abnormalities with inherited, really, insulin resistance and the mechanism of inheritance something that we can actually characterize and then perhaps something that we can figure out a way of treating. So a couple of other things, interesting things that came up. Here's Oleski's group looking at transcriptional coactivator PBZ binder, TAZ, which is an endogenous organic inhibitor. And that appears to be a factor in insulin resistance. Okay, if you knock out TAZ and then compare the effect of knocking out TAZ to the effect of administering rosiglitazone, thiazolidine diamine, you can see interesting differences. So both of them increase PPAR gamma, both of them increase insulin sensitivity, decrease free fatty acids, but the thiazolidine diamine, as we know, is associated with weight gain and particular increase in adipose tissue mass, whereas in this TAZ knockout model, you don't have increased adipose tissue. There's increased number of small metabolically healthy adipocytes. So maybe this will prove to be a pathway for pharmacologic treatment without the baggage of the thiazolidine diamine. And then here's a very interesting study, again, just came out this year from Phil Scherer's group. And so the original idea with leptin was, okay, leptin is going to be the key treatment for obesity, and if we simply administer leptin, we'll be able to take advantage of that to improve insulin action, cause weight loss, and so on. Turns out that that's not so easy, only works in individuals who have congenital leptin deficiency, which is an extraordinarily rare situation. But what Scherer did in the study, which is reported in Cell Metabolism, Cell Metabolism is a fascinating journal for me to look at because it has so much pertaining to metabolism and diabetes. And if I ignore the articles that I can't possibly understand without talking to you, Chris, there's still a lot of interesting things. So Scherer has this model of looking at partial leptin reduction. So obesity is associated with elevated leptin. We don't know why that, and then we wave our hands in the air and say, well, this is leptin resistance. So in this animal model, using a leptin neutralizing antibody, you were able to improve leptin sensitivity in the hypothalamus. So whether that will again prove to be an interesting way of treating insulin resistant states remains to be seen. Let's turn to the branched chain amino acids in the last moments. So branched chain amino acids are essential amino acids. They're present in the cytosol and in the mitochondria. They're used for protein synthesis. They're used in metabolism. So here's a complicated set of pathways. The nitrogen released from branched chain amino acid metabolism is then transported to the liver. It's part of the production of urea. And there's a cycle with some key enzymes, branched chain transferase and branched chain ketone keto dehydrogenase, leading to entry into the TCA cycle, important in energy metabolism. Branched chain amino acids play a role in energy metabolism in muscle and in liver, involvement in protein synthesis, involvement in glucose homeostasis, energy regulation. So there's some very straightforward associations of branched chain amino acids with our diseases, with obesity, with insulin resistance. So another very important set of names. So Phil Feeling, who is was really a key investigator in all aspects of diabetes during my fellowship, and then kind of fell off the map in a study in a slightly sad way. Another story, but utterly brilliant. So here's one of his early neural studies, and an association of valine, isoleucine, and leucine with obesity. And so he proposed this interesting linkage of obesity, insulin resistance, hyperaminoacidemia, particularly those leading to hyperinsulinemia. This is 1969, when there were a tiny number of articles out there in the insulin resistance area. Here's, I'm only showing this for historical interest. This is my fellowship study based on these complicated portal vein catheterizations that I maybe did, but really the Phil Williams, who was the lab technician, did all the work, and Alan Sherrington set this up, and Alan has gone on to do a huge series of important investigations using this kind of model. So we found that if you look at branched chain amino acid entry after ingestion of beef, you find that it appears in the circulation without any hepatic contribution. And if you administer beef with either oral or IV glucose, you show that there's in addition to the entry of amino acids from the gut, there's additional entry from the liver, and exactly what the mechanism of that is unclear. And it really has little to do with this talk, except I want to. Yeah.
What did Oscar Crawford say?
He was, he liked it. I mean, he actually got really bad at it because one morning I told Phil that I would pick up the NIH investigators who were going to do a site visit, and Phil could get the study started, because these were incredibly complicated studies. Anyway, I got lost or something. And Oscar was embarrassed, and he got the grant eventually. So this is an article from Chris Newgard, who came here and talked about this, and kind of piqued my interest in branched chain amino acids. Looking at an animal model of branched chain amino acid feeding, which was less associated with obesity, but similarly associated with insulin resistance. And so if you look at branched chain amino acids in population studies, they track with insulin resistance, but here's the insulin, the IRAS, insulin resistance atherosclerosis study, and branched chain amino acids were associated with decreased insulin response in non-Hispanic whites and Hispanics, but interestingly, not at all in African Americans. So there are probably a lot of genetic variations. Here's a GWAS, branched chain amino acids versus insulin resistance, the same, what again comes out is isoleucine, leucine, and valine, the three branching amino acids. Here's nurses' health study and the health professional follow-up study showing that as you go to increasing quartiles of leucine, isoleucine, and valine, you find an increase in insulin resistance. Dietary branching amino acids, association with insulin resistance, perhaps particularly with valine. And so there are two kind of existing hypotheses. One is that insulin resistance itself increases branching amino acid levels so that the skeletal muscle doesn't respond to the anabolic effect of insulin. There's increased proteolysis and branching amino acids are released, or alternatively, that branching amino acids themselves cause insulin resistance, maybe with a defect in branch chain keto acid dehydrogenase, leading to this whole pathway. So that is my really very high up view of some interesting aspects of insulin resistance. Historically, going back to the insulin binding antibodies, uncommon but interesting. The discovery of insulin, so really insulin wasn't discovered in 1920 by Anthony Betts. It was discovered in 1960 by Burson and Yellow, because without measuring what we're talking about, what is it? And then looking forward, insulin resistance is not just a metabolic phenomenon. It involves heart, brain. We didn't talk about the cancer association, but that's tremendously important. This effect on immunity, what are the mediators, branching amino acids, and I didn't talk about lipid mediators, ceramides, and so on, this affecting microbiota. So that's my story.